Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. Today we're joined by Dr. Sebastian Rodriguez-Elizalde, an orthopedic surgeon at Humber River Health in Toronto. And Dr. Rodriguez has helped build rapid discharge pathways within a large public healthcare system in Canada using Anterior approach. He's also deeply involved in surgical education and the evaluation of emerging technologies. But today's conversation goes a bit beyond technique. We're talking about what happens after fellowship, how surgeons evolve, how teams can shape your consistency, and how to adopt innovation without losing judgment. Sebastian, welcome to the AHF podcast.
Good morning, Joe. Pleasure to be here. Really excited. It's been a long time. Been watching you guys, obviously, with my involvement with AHF, and pleasure to be on the show today.
So before we get too technical, I want to start with something you've said in one of your interviews in the past. You've described surgery as choreographed, almost like a dance. And I just want to ask simply, what do you mean by that?
I compare surgery to a lot of things, first of all. But yes, I do compare it to a dance in terms of when you plan out your day, right? So by the choreography, I mean that you've prepared and rehearsed, if you will, be that practice, experience, or learning, many different techniques. And then you put it all together when comes time for surgery. And while every performance, if you will, is a unique experience, it's sort of based on that collective understanding, knowledge, and experience of the surgeon to get through that procedure. And even that day, the whole day is a choreograph, right? If you're trying to move through a large number of cases. So that's why I like that analogy a little bit.
So people who are thinking choreography, thinking dance, they're thinking of following a beat. Are there particular beats that you're paying attention to throughout your day?
Absolutely. And I mean, some of these things are things that, I've learned from witnessing other surgeons in terms of lots of surgical efficiency sort of discussions and mentorships that I've gone through. And I think the key thing is measurement. So in terms of those beats that you're talking about, that cadence of surgery in a surgical day, I think is important. So that cadence involves the preparation and then bringing someone into the operating room, the cadence of getting ready, and every step that's part of that procedure, how you're going to approach that. So I think it is important to maintain a healthy cadence that you're aware of during the surgery and during your day. Where am I? Where should I be at this point during the day, assuming everything is going well? Assuming everything is going well in the surgery, are we near the end of the procedure? Are we near the end of the day? Am I mentally sort of thinking about the next case and the next patient as we're closing, that kind of thing.
And when you're sort of appreciating this choreography throughout the day, appreciating this dance, when you notice it's starting to break down, where does that usually happen first? Where do you see the biggest issues?
I mean, that can be a lot of things. I think most important is that you notice it breaks down, right? Because previously and before, you'd be going through a day and then all of a sudden you realize, hey, I think we're behind by a couple hours. Am I going to finish on time? And here in Canada, in a public healthcare system, obviously there's constraints, in terms of finishing at a certain time. Will your last case get canceled? That kind of thing, which, I mean, it could be foreign to a lot of my US colleagues. If you own a surgical center, you just do whatever you want to do to finish the day. So, in the past, it was very important for us to make sure that we were on time, but without measuring and being aware of it, you could easily lose track of where you were in that day. I think now we're much more aware on a per case level where we should be, and on, even per procedure level. Like how long does it take for me to get to reaming the cup? Or how long does it take for me to get to, putting in the broach or to close the wound even? So all those little steps you have to be aware of. If you notice your day is breaking down a bit and you're falling behind, I think two things is: one, don't panic, because the last thing you want to do in surgery is rush. You want to make sure that, that Napoleon once said, "I'm in a rush, so go slowly," when he was asking someone to get him ready for war when they were surprise attacked. And my dad loved that quote. So I think the key thing is if you are falling behind, make sure that you're still prepared and following protocol. You don't want to cut corners at any given time. But I think you do have to be aware of, maybe this case is going a bit slower. Maybe this patient has a higher BMI or is more muscular, or I'm struggling a little bit more for exposure. That's not going to be every case in the day. And understand that, well, you know what? Maybe we'll make up that 5-10 minutes on the next one or two patients if they're a bit slimmer. So you have to understand that within a day, there's guidelines, but there's still variance and flux so that
Mm.
you can go, you can go fast to slow if you need to, as long as the overall average of that day gets completed. But the biggest thing you want to do is just make sure that those mileposts, if you will, that you establish for yourself are being respected. They don't have to be adhered to 100%, but respected to the point where you can be like, okay, well, I know I have to get to point B from point A. If we're a bit behind, then the next one will be a little bit faster. That's all.
Hmm. And how important is it to you when you're looking at those mileposts that you talked about? How important is team rhythm in keeping adhering to what you want to accomplish for your day?
I think that's paramount to your success. I think what we've really learned in the surgical efficiency work that we've done here at Humber is that the success is not surgeon success. The surgeon can be captain of the ship, but the ship still has an entire crew which makes it run.
Mm.
And that the more you understand that everyone has to be motivated and understand the goals of the day and be the leader in that front, I think that is the key takeaway that we have learned. If your surgeon is unaware of time, uninterested in time savings, uninterested in efficiency, or unaware of what's going on during the case, you can't expect the team to be able to all of a sudden help you out from that perspective. You have to be the leader in that regard and set the pace, and having people that are all understanding what your goals are for that day. And our goals are, let's say, to treat 10, 12, 14 patients in an 8-hour window safely here at Humber and get them all home that same day. Everyone understands that before they walk into the operating room, and everyone picks up where we're going on. Sometimes it involves our assistants helping take out the garbage. Sometimes it involves having an extra pair of hands to clean. Sometimes it involves, for one of the cases, maybe the staff person will close that wound and not the fellow or not the learner if they want to make sure that we're done on time. So those little modifications, the entire team understands, but having that team first philosophy, I think, is paramount to success.
Hmm. And we're going to get a little bit more into your team philosophy in just a little bit, but you did mention, you're working within the constraints of a public hospital system in Canada. And a lot of surgeons, a lot of people listening might not fully appreciate what that means. So can you tell me a little bit about what sort of real constraints you deal with on a daily basis?
So I often think, there's this huge misunderstanding of the Canadian healthcare system versus the American healthcare system, right? The reality is actually they're much more similar than people will give credit to or understand, right? The Medicare world and the OHIP, or Ontario Health Insurance Plan, as we call it here in Ontario, at least in our province, are not dissimilar. So in this case, this is a taxpayer system where everyone contributes taxes to have a healthcare system whereby healthcare is provided, for free, but really it's taxpayer funded. So it's nothing is for free in this world, as you know. What that means is the hospital is allotted, based on regional populations, a volume of procedures to do during a given year. Within that volume, there's still some variance that happens year to year where you're allowed to do more procedures or less procedures based on performance, incentives, if they have more money from another budget. So that number is not set in ironclad stone. That being said, generally speaking, OR days run at a set time. So it's not a surgical center where you can run overtime and pay people more if you want to. Things like overtime for staff, we're sensitive to. Prices of implants, we're sensitive to. Additional technologies and their costs, we're sensitive to. So the per case cost in Canada until recently was not well understood or analyzed. A lot of these financial sort of motivations and understandings are now coming to light about how we can be more efficient and more time saving and more economical in the procedures that we do. So it's not necessarily at surgeon discretion at any given time what they're going to be able to do. You can't put a ceramic hip in an 89-year-old, that's so
Mm.
you have to understand that there's give and take in the system, overall with the mindset of being that the more fiscally responsible we are, the more people we can help treat, which translates to the more volume of cases that can be done globally as a system. So all that being said, we have constraints in terms of the day and when it finishes. constraints from some of the technologies that we used. And these are all fiscal things, right? And in terms of the implants that are used, and you have to have generally good scientific backing or understanding of why you're going to change any one of those things, be that for research, education purposes, or a younger patient needs a different type of implant, or I feel a robot or an additive technology makes me a better surgeon, that kind
Mhm.
of thing.
So, as you were starting to increase efficiency and maybe push the envelope of the number of cases that you could do in a given day, what was the hardest part of sort of pushing change in this type of system?
I think it's inertia, right? Because I think any system change, especially a bureaucratically run provincial healthcare system here in Canada, is like dealing with your government, if you will, right? So any change at a government level is hard to implement. And then the other thing is having a proof of concept, right? Because whenever you do more volume or try to look at efficiency, that generally translates into more procedures per given day. The number one thing for resistance that we encountered was a lot of safety concerns is, can you do these procedures safely in a shorter time span and more in a day? And are you as a surgeon still able to guarantee, responsible clinical outcomes? Is your anesthetist feeling safe enough to be able to deal with these patients? And the nurses who discharge these patients don't feel so rushed that this is unsafe. So we addressed a lot of the safety concerns individually. I think a lot of that brought, stakeholders to the table to say, hey, what are you worried about? Because often, and I was guilty of this, seeing something from my lens as a surgeon, I didn't understand why other people were so resistant to this idea. To me, it seemed like a great idea. But you
Mm,
have to understand what it is that their motivations are and what their concerns are and address those. And maybe they're not important to you as a surgeon, but you have to understand that these are all barriers in the system that if you don't address, you won't be able to progress forward. So
mm,
I think, addressing all the potential roadblocks and barriers, be it anesthesia, nursing, administration, even things like portering, EVS, or housekeeping in your room. You have to be able to talk to all those stakeholders and understand what it is that you need to do your job safely. Is there a way that we can potentially be more efficient or do it better or potentially do it faster without causing undue stress and trim the fat, if you will, out of any system? And when you break down any process into all those little pieces and look to see how you can make each part of it better and talk to the stakeholders that are in the best position to understand the problem, you can really make a lot of change.
mm. Was there a moment during this process where dealing with that inertia felt too difficult?
Yeah, every step, obviously. I mean, like inertia is inertia. Like you have to be, like I tell my fellows and residents, you can't be a small wave, that's just crashing against the shore and makes a lot of noise. You have to be that one tidal wave, which is just a slow moving but immovable object that's constantly moving forward. And that's what you got to be, is just you have to keep going and start low and slow. And it builds to a point where you realize you just can't change the change of that tide, if you will. And
Mm,
so inertia is one of those things. I think I learned number one is you can't get frustrated, right? Because I think as surgeons, generally, I don't say we have short fuses, but we have, we like to fix things. In orthopedics, we like to fix things quickly.
mhm,
Some of these things take time, and you have to let some ideas pollinate and gain traction, have proof of concept. You won't convince everyone all at once, is the other thing I learned. You have to convince a few key stakeholders, create proofs of concept, be able to expand those ideas and make them scalable. And I think that's really what I learned about change, was that you're not going to convince everybody on the first day, but by the 10th time you've done it or on the 100th day, you'll realize that this is the new standard of care.
mm. Did you come out of your fellowship training with this sort of plan in mind that you were going to be seeking this kind of efficiency, or was this something you developed after you became sort of fully independent?
Definitely after I became fully independent, after my last fellowship here in Canada, we do several fellowships, as I'm sure you're aware, and I
Hmm.
I went through the rigors of three actually in trying to land on the right job. I did my master's in health administration, and essentially that's a parallel stream to an MBA, if you will, with a lot of healthcare in the second year. That's when I really got a new appreciation of, especially in Canada, system change, because you have to be able to talk to administration and politicians and people that, as surgeons, clinically, we're not educated on that. We're educated on how to be technically very good, how to learn, but anything that extends beyond the operating room, but to the care of the patient, we're not well versed in.
Mhm.
So my master's of health administration gave me a lot of tools to speak about what is a business case? How do you put together the business case? Who do you talk to when you have a business case? Where do proposals go, and how do you affect change? A lot of that came from my master's in health administration, and then from experience. And then finally for efficiency, it came from the Anterior Hip Foundation. I mean, a few years ago, we had a talk on efficiencies, and I was up there listening to, Charlie and Kristoff, and they're talking about banging out 14, 16, 18 cases in a day. I was like, holy shit, I'm fast, but that's really fast. And so it led to emails and conversations, and then, and surgical site visits, and bringing our surgical team to those visits. So it wasn't just a surgeon saying he or she wants to do more. It's about the entire team understanding that we can be better. And that's
Mm.
all I challenge people to do is like, whatever we're doing, we have to constantly seek to evolve to be a bit better version of ourselves. And if everyone takes that mentality, you can achieve amazing things.
Mm. When you were thinking about those efficiency tactics and sort of reflecting on what Charlie was doing and what Kristoff was doing, was there a case or a moment, not necessarily the hardest case that you've done, but one that changed how you started to think about efficiency, or how a case that maybe reshaped your judgment about this whole process?
What really reshaped, to be honest, was probably when I visited Charlie. I remember the thing that I took away the most with Charlie. I mean, and Charlie has an amazing practice, and I think everyone should go visit Charlie if you're in the US to get an idea of efficiencies in the surgical setting. Uh, was, the software and how we mapped out measuring every process of that. So, I'm not sure if we can use like, terms here, but it was basically an Ospitec, or, a one team type solution, if you will, that broke down the surgery, had the entire surgical plan on a board for everyone to see, and timed each part of the procedure, whereby you had your average time for that procedure and then your average time for each part of that procedure. And that's when I started thinking about surgery a bit differently. I thought not about it as a procedure, but as the accumulation or the sum of a lot of small parts that have to get to you to that next step.
Hmm.
And when you start to think that way and you start to measure that way, then you become aware of yourself. And when I came home, the first thing I did is I got someone to measure. I said, look, we don't have that software yet, but I'm like, write down all these time points every time. And because we as surgeons are always the greatest or the fastest or the best or never have complications if you talk to any one of us, right?
Right.
But it's very humbling when an objective person will measure you. And so we have a lot of data for a lot of the measurements that we do in surgery. And I'm sure they're the same in the US and Canada if you look at infections or dislocations or reoperations. But the pieces of that surgery and to get there, we don't really measure, or historically have never looked at that, right? And so that data to me was quite fascinating and quite enlightening in terms of procedural improvement. Because based on that, when I even went to go see Kristoff in Belgium, just technique wise, a couple of the things that he did, I started adopting. And I realized, in this part of the operation, I'm actually faster. And I can tell because even the anesthetist said, your procedures are faster. And we broke down, we were able to figure out which part of the procedure I was faster at because I had adopted, new learnings to. So yeah, it was very interesting to see the data that I made on myself and be able to make on a procedure to be able to self-improve.
I'm going to get to those efficiency sort of mini fellowships that you did in just a minute. But before we get there, you didn't start out doing anterior approach. You started in posterior approach, is my understanding.
I did.
And
So
tell me about
go
that.
ahead. Well, I trained in Ottawa, which is the capital of Canada, and Dr. Paul Boulay brought anterior approach from Joel Matta there. I guess that's now, I don't know, 25 years ago or something, when I was in the middle of residency. So as we all know, Joel is sort of credited being, the godfather, if you will, of anterior approach, on the West Coast of the US. And his disciple, Paul Boulay, was actually working in California with him for several years before coming back to Ottawa. So Paul really is credited for bringing anterior approach philosophy and that surgical technique, which is sort of experimental and very, limited in all of North America at that time, and brought it to Canada, made it part of the residency and fellowship training. So we were exposed to that as residents. And so I had seen the anterior approach and knew about the anterior approach and the purported advantages. At the time, I mean, this is so historic. Patients were kept in hospital for 4 days, right? 3 or 4 days.
Mhm.
So, people seem to have less pain, but it didn't seem to lead to a faster discharge just because, we thought mentally all these patients had to be in hospital.
Right.
And then when I went to HSS, everything was posterior approach. So back then they were just starting to dabble in anterior approach, Jose Rodriguez and Dr. Alexiadis, a couple of guys just starting, but it was still very much in its infancy. So I came out trained mainly as a posterior revision and primary surgeon, and started my career that way. Then it was really in the early days of my career that our administration had gone down to Colorado and seen a surgical center, and they said, "Hey, these guys go home the same day. They're doing anterior approach hips. How come we don't do this in Toronto or in Canada?" And so administration wise actually approached me and said, "Can you do this?" And I said, "Well, actually I was trained to do that. We need a special table. If you support me in getting a table and doing a trial, maybe we can start to do this surgical technique in Toronto in our hospital." So they did. We trialed a HANA table. I went back and relearned anterior approach with some site visits with some colleagues. My first few days, they came and helped me out, and then started doing everyone anterior approach back in 2016 or 2015, I guess. We just sort of switched, and everyone went to anterior at that point. So it was relearning something that I was aware of, but I had to get comfortable in again to do it.
So, speaking of that, what part of that was harder? Was it the technical learning curve, or was it more the psychological learning curve?
I think it's both. I mean, I was still a few years out of fellowship, so it's still pretty early on. But even, what struck me is at that point, I felt like I had refined my posterior technique. I felt like I had a very small incision. Really, is there a difference between anterior and posterior? I'm really good at posterior now. That's how HSS trained me. And I was comfortable. And I realized that you can very quickly become, we always said like, oh, those old guys are never change what they're going to do. Like yeah, I'm a new young guy. But very quickly, that mentality I had was, you can get very comfortable and see why people don't want to change later on in their careers. So it was a struggle because you feel like you're very good at one thing and you're going into the unknown. So it's an ego hit because you realize you're not going to be as good doing something new, that you're very good at doing something old. You have to promise yourself that you're doing this because at the end of the day, it's going to be better for patients and hopefully better for me as a surgeon to offer better quality care. And there's a reason that I'm changing my technique. And you have to stay that course.
Hmm.
Then technically to relearn stuff that you haven't seen, and now you're looking at it through the eyes of I'm the attending and not the learner. I have to do this fully without someone watching me. Yeah, those are big steps and big, anxiety provoking things. And as much as every hip surgeon says, I know how to do a hip, but when you do it from the front, it's like a new operation. You can't think of it as like, well, I do a hip, this is the same thing, but I'm just changing a couple of things. You have to really rethink the way you think about the hip when you do it from the front.
Yeah.
So those things all caused a bit of anxiety. I think part of it was I was young enough and naive enough that I assumed it would be easy and could do it. You know what I mean? Like I didn't overthink it. You just
Yeah.
sort of do it, and that's sort of like like children, right? They just adopt a new thing and they don't overthink it. Whereas, trying to learn to ski when you're 45, you're going to way overthink that, right? About what if I fall? So I think I was still young enough that it seemed like it should be easy enough to do, and lo and behold, here we are.
So, did you ever have significant doubts about the decision to do that?
In the first couple of days, the first few days that I was operating, I had Brent Lanting, who's a colleague of mine from London, Ontario, who does a lot of anterior approach hips. Good friend. He came up and helped me. And so I felt comfortable. Like he let me do the cases and was there to bail me out, give me tips and tricks. I'd been to a variety of training courses, but, for sure, the first day that I was on my own about, you have a bit of a harder case and you're wondering, like, why am I doing this? This is so much harder. Right. And then I made the decision to go wholesale all anterior early because I know myself and I know that if I pick and choose, you can always make an excuse to not do something hard. This
Hmm.
patient's a bit bigger. This patient's a bit more osteoporotic. This patient's overweight. This patient's too muscular. We're behind on the day. Maybe I should just do it from the back. I didn't give myself those crutches. I burned the ship, so to speak, and I just stayed on the beach and just kept going. So there was no retreat at that point. But many a time that I have doubts during a case, if things are taking longer, um, and you are going to be frustrated when you learn something new. And especially, I think when you're a more experienced surgeon trying to relearn something new because you've spent years honing and mastering that craft that you're very good at doing in one particular way, and relearning something has to involve the fact that you are going to make mistakes and be slower and not as good as the guy next door that maybe has been doing it for a long time. You have to stay that course. And I think for a lot of surgeons, maybe they dabble in anterior approach hip after a weekend course. This is too hard, or they have a complication and then they bail on it. They don't do it. And we saw that in Canada and even in the US, like a lot of people early adoption failed. And I think that now with better training programs, better support, better mentorship, a lot of those fears are taken away and we're able to support those surgeons better and have better education so they don't fail.
If you're doing anterior hips or if you're thinking about it, let me just say this: AHF events are different. You won't be sitting in the back of a dark room watching slides all day. The content is practical and technique driven. And the AHF is a real community. You can stop anyone in the hallway and ask, "How are you handling this exposure?" Or "What are you doing in this revision?" And they'll walk you through it because that's the culture. If you're early in your anterior experience, there's a fundamentals track focused on technique and complication management that you can use Monday morning in your own OR. But if you're extending into complex primaries or revisions, we're already there, having honest conversations about what works and what doesn't. And we have pre and post meeting anterior hip labs for every stage of learner. There's something for everyone. More importantly, it's a group of surgeons serious about continuous improvement. AHF 2026, entitled Consensus and Controversy, is June 5th and 6th. You can see the program and register at anteriorhipfoundation.com. If you've been thinking about coming, come. You'll leave better than you arrived. I'll see you in Nashville. So you spoke about this kind of, I would say, a bit generally, but specifically, was there something you learned about your own ego going through this whole process?
Yeah, that is more fragile than I would have ever admitted to. You know what I mean? Because I think that's all of us as surgeons, but certainly for me, is that like, yeah, it's humbling. Like learning something new is humbling. And I think going through that made me more aware of one, as you teach other people things, and two, awareness of myself to be able to adapt to new things as I move forward.
Hmm. So I do want to go back now and talk a little bit more about the time that you spent with Charlie and with Kristoff, because not only did you go, but you made sure that your team went with you to see
Yep.
how those clinics function. So I want to start with, why was it important to you that your entire team saw what was happening?
I think that was key because I've seen so many times surgeons go see something new or have a new technique or toy, and they want to bring that back to their institution. I mean, this happens in Canada periodically, and you have to validate it to the administration and say why should we change, or why is this costing more? Why can we do this? And that relies on the surgeon explaining why he or she has done something without everyone else understanding that it could be done and could be done safely. I didn't think it would get off the ground. And
Hmm.
so because we had a lot of fears of trying to push the boundaries of going from 3, 4, or 5 cases in a day to double or more of that, there was going to be a lot of friction and resistance. And so I thought it was important that the people in the recovery bay that take care of these patients, the pre-op nurses, our Zimmer rep even, I wanted him to come, administration to come. In subsequent visits, we've taken anesthesia down because, the anesthetic process that he has there compared to what is normative in some other places is totally different.
Yeah.
Um, I think it was, and even our scrub nurses and OR nurses. So the girls that set stuff up for you, right? And take things down, and just for them to see what could be possible. And again, my takeaway wasn't to have the team come back saying, okay, we're doing 16 cases on Monday. The goal was to come back and say, like, look, we learned that we can measure and be better at what we do, and maybe we can do my idea is sort of like 20% more, right? So if you do 3, do 4. If you do 4, do 5. Just be one extra case better and see where that takes you.
Hmm.
And by having everyone there to see it, and I really think that, Charlie talks about it. You have to see it. Like you have to see how fast things are and how fast things can be, and still done at a very high standard and safely. once you see that, it totally changes what you think can be done. And at least for me, part of this process wasn't just if I could operate faster, it involves the entire system changing. So we needed people from the system to be there to witness it.
Hmm. Were there things that your team identified or noticed that you hadn't?
100%, everything. So I'm focused on Charlie and the surgery because I'm trying to feel what can I do better for my surgical technique. But the scrub nurses came up to me and they're like, Dr. Rodriguez, when we come back, we're going to do this and we're going to do more. And Odette, one of my favorite scrub nurses here at Humber, said, I'm going to make sure that you don't ever ask for an instrument and we hand it to you right when you need it before you even ask for it every time. She's like, we can do this. And she's like, we can help do the takedown while you're closing to help get the case done faster. Um, you know, uh, the nursing and administration all identified areas that, some things could be replicated and some things can't. So this is a hybrid Canadian version of what you will, of surgical efficiency. There's less bodies in the room compared to what Charlie has, if you will, in terms of number of people. So everyone had to pick up extra jobs. So our surgical assistants here, help with some of those roles. So everyone actually identified stuff that he or she could do and brought it back. It was actually not me dictating it. And to be honest, it worked out better than I could have ever thought because it wasn't me telling people they needed to do things. It was people identifying like, hey, we can do this and make it better. And I think that level of engagement, I think, is really what made the whole program a success. Because without that engagement, you don't have a team-centered mentality.
Mhm. And as you're hearing from surgeons nowadays who are trying to implement these sort of anterior rapid recovery discharge protocols, what are the mistakes that you're hearing that surgeons are trying, specifically in terms of if they're not aligning their entire team?
I think that's big because you have big resistance in terms of safety, right? There's a misperception that because something is efficient and fast, it's unsafe. And I argue personally that, look, the more you do of something in a day and the more it's replicated, the more standardized it has to become. And standardization is the key to any successful operation. I mean, like, that's why pilots have a standardized flight checklist, right? And they go through everything the same time. We do a pre-op checklist, but like surgically, there's a lot of variance. And so the more we can decrease that variance intraoperatively and the way we approach things, the safer it'll be. To the point where if we're running two rooms, we have to make sure that one room's all right side, one room's all left side. So there's no confusion.
Hmm.
There's no setting up of the C-arm or moving the tables over from right to left. Everything is very seamless as much as possible in that regard. So I think um, you really have to understand that there's going to be a lot of resistance, mainly in terms of safety, mainly in terms of, you know, can we get things turned around just as fast? But you realize if everyone pitches in, you don't need 35 minutes or 45 minutes to clean a room. You can do something very safe to the appropriate standards in 10 minutes or 15 minutes. And
Hmm.
even your anesthesia colleagues, getting them on board and seeing how long a spinal anesthetic lasts, you don't need them to be paralyzed till the next day. Like what we used to do, we used to give them such a long spinal for pain control and epidural that they wouldn't walk until the next day. So there was no thought process as to how long does this spinal last.
Hmm.
Now that we're getting people out the same days, we've reevaluated the role of spinal anesthetics and the medications we use for those and how long they last because we need this guy to walk in 3 hours or in 2 hours, right? So
Right.
totally changes the way we've approached those things.
So, as your system becomes more efficient, are there things that, to your mind, are not negotiable? Like, what would be your three non negotiable? Can't change these no matter how much more efficient we want them to become?
It's a great question. I think non-negotiables number one is I think it is anesthesia. You need to make sure that your anesthetist or whoever's providing that is on board. And in terms of blocks or periarticular blocks or anything that's done by the anesthetist, they have to understand that you need to have this person fully mobile and walking within 2 to 3 hours. And however long it takes you to establish that preoperatively, be it a spinal anesthetic, if you need 20 minutes to do a spinal, then you have to leave the room and get ready for that patient like 25 minutes ahead of time so that you're ready to go. So I think having a good relationship with your anesthetist and being able to communicate what you need and making sure that they can deliver that consistently is the other thing. I think is very important.
Hmm.
The second thing I think you need in terms of that is having an experienced team. you can do a hip anywhere at any given time. Doing it like you do back home or whatever with your normal team and setup, I think is like home field advantage. So you need to be able to have a core group of people that you work with, be it, a scrub tech in the US or an assistant, someone that makes you better. And I think good assistants make you better.
Hmm.
So that be it a scrub tech or a nurse or a physician that's helping you, if they can anticipate your next move before you're doing it and help you, that makes you much more efficient. So having a familiar face in that regard, where you're not having to explain every step of what you're doing and what you need them to do, but they know what it is that they're doing, I think is very important. Um, and finally, I think your nursing team that's with you. So on any
Hmm.
given day, the nurses on the back table, the people that understand the implants and how to open them, the people that understand that you take every, screw hole out and you need to have that prepared before you put it in a cup or not. Um, do you have a screwdriver ready? Things that are ready on the back table. And even beyond that, they have to be consistent and understand your flow. So if you have those things like your nursing, your assistant, and anesthesia all there, they're on the same page and have worked with you and understand what the goal is, you'll have success.
Hmm. So you did this change of your own practice, moving from posterior to anterior, and then you undertook this culture change, moving towards a more efficient operating room. What was harder, refining your femoral exposure when moving to anterior approach, or changing the culture of your public hospital?
I think it was both. Both have different challenges. One is you personally are challenged technically, right? How can I become better? And anyone who's ever learned anterior approach also has this aha moment when they realize, oh, how I can deliver the femur. I just have to remove this capsule here and things pop up and I can see it, right? You have to go through those iterative changes where you're just like, oh, I didn't realize or appreciate that. And now I can do that better. So definitely there's those challenges there that one day either you discover or someone shows you a trick and you're much better at doing it now all of a sudden. There were a lot of those for me personally, obviously over the years. And then even after when I went to go see those other surgeons again, really reinvigorated me, Joe, because I was watching someone else do these procedures again and again. And I was like, I never thought of doing that. And I
Hmm.
started implementing little tips and tricks because even after several years, you think you've developed your own technique and is very good, but then you go see a couple other people and you pick up things. And if you can adapt that and constantly like learn, I think that was refreshing to me that there's always room for improvement and enlightening to me to be like, you know what, just because you've done something well doesn't mean you can't get a little bit better if you start to adopt or look around to see what else is being done.
Hmm.
In terms of the system change, that's harder because a lot of that's out of your direct control. When you're operating, you have direct control of what you're doing. When you're trying to get a process and a system change, that's much more challenging in some regards, right? Because you're limited, if you will, in terms of how much you can convince other people. So you have to put your best case forward and but it's out of your power, which is I think hard for surgeons to give up because they can't just say change, it has to be accepted by all.
Yeah, a bit of a negotiation sometimes, even.
Life is a negotiation as Voss told us, I think, at the last meeting. So yeah.
So you've touched on the use of surgical technology and innovation within the efficiency space, and like you mentioned, in a public hospital, every dollar matters. So when you're evaluating some new technology, what sort of internal filter do you use? How do you go about that process?
I think we struggle with this because all new technology and innovation comes with an upfront cost a lot of the time. So you have to justify that either by research or by education and understanding that this may not be efficient or save you money upfront, but we anticipate that with this implementation, it will down the road. And so you have to get people to buy into the fact that efficiency doesn't mean today in the operating room. It means like, what does this look like in 2 years, 5 years, 10 years? What does it mean at a societal level if we have less revisions and less complications in a public taxpayer sort of scenario, being able to sell that idea and that vision? And then being able to make compromise. Whereas, like, let's say we want to use ceramic heads, metal, cobalt chrome heads are, half the price or less here in Canada. And using a ceramic, a bearing surface is much more expensive, but we're allowed to do it. But to be able to do it on everybody isn't necessarily, feasible, nor is it necessary, as we know. So it involves making compromises to be like, look, we're going to use better implants or newer technologies, but understand that maybe not everyone gets it. And be able to make compromises down the road of like, okay, well, maybe we'll do a little bit less of X if we want to really get Y.
Hmm.
So you can't have everything all the time is really what it comes down to if you want to use technology and innovation. So it means picking your battles, and it also means being able to create, a model where you can prove what it is that you're doing has value to the system.
Hmm.
Um, it's just hard to see that value for tomorrow or when you're first starting.
Have you ever been really excited about a piece of technology and then suddenly realized maybe it's not the right move?
For sure. I mean, lots of stuff like um, let me think of a good example of that, but I feel like that's almost every day. But yeah, in terms of new technology that we wanted to use, I mean, I don't want to get into specifics with that because of, companies and devices and stuff like that. But for sure, like, the implementation of navigation technologies in both hip and knee replacement, obviously, I'm a tech guy. I love tech. And, initially when we started doing that, even on the knee side and navigational technologies, as on the knee side, never really bore out huge clinical advantages, 10, 20 years ago when we were using them, even though intuitively made sense to be more accurate.
Right.
And then, but took a lot longer with some of the early versions of navigation in knees, if you will. Now we have a new generation of robotics where it's a whole different story in terms of what you can evaluate and how you can do it, let's say in knee replacement. And so we're being able to revisit that and hopefully now have proof and show how it makes the surgeon better and the patient better. But it's easy to get excited about new technology sometimes, and then you're right, you have to take a step back and evaluate, like, is it worth it? Is the juice worth the squeeze? Is the financial cost, involved? Is the learning curve, is it all better or not?
Hmm.
And that can definitely take some honest reflective feedback that you might not always like the answer to, right? Because you invest time and effort and money to get some of these things, and then to realize that you may not actually need them or be, benefiting from, I think is humbling. But I think you have
Hmm.
to be open to that.
It's interesting you mention the sort of navigation in total knees because some people online certainly and some surgeons that you talk to would argue that the technology was great, the alignment strategy was what was off, and
Yes.
it might not be that the technology is the problem, but that our understanding is. And
I
what's
agree with that fully.
Yeah, and what's
Like,
interesting about that is, people. I think there's a lot of concern going forward about technology replacing surgeon judgment instead of enhancing it. So, as you're looking at different pieces of technology, how do you think about that concept of enhancing your judgment as opposed to substituting for it?
um, well, I think we're getting there, to be honest with you. I mean, uh, I think technology is accelerating at a pace that not many of us fully understand, I would say. And the
Mhm.
learning algorithms of machines, I think, is going to far exceed surgical judgment in my lifetime for sure, and probably pretty quickly. And I say that respecting all our, knowledge as surgeons and our experience, but any process that's a mechanical process that involves, us doing stuff naturally seems like a navigation or robotically assisted will slowly penetrate that market. The judgment, I mean, some of these tools to be able to discern, alignment strategies in knees, cup placements and hips, AI is going to be able to do that a lot better than we are. Like,
Mhm.
the imaging AI like that they have to read x-rays and CTs is just now, getting as good as radiologists, and shortly will probably be better. The natural extension of that is that, for us clinically to make a judgment on positioning, soft tissue tension, alignment, I think it's natural that these technologies are going to evolve to the point where they can better do some of those processes than we are. I think you'll need a surgeon to be able to guide the robot, to make the clinical decision, to approve a surgical plan, to understand the nuances of that patient. But I think very quickly, a lot of those decisions that we were taught, that relied on years and years and years of experience, that's basically all experience that can be fed to a machine and the machine can do at some point.
Mhm. So you're certainly still young in your career, but you've had enough of a career that you have the ability to kind of reflect back on how far you've come. And you're probably at the point where you get to start thinking about what type of legacy you get to leave behind. So, a couple of questions regarding that. If a surgeon, much like you, is now just a year or so out of fellowship and in a public hospital, let's say in Canada, and they're feeling overwhelmed with their system, and overwhelmed with what they're asked to do to take care of patients, is there any advice or anything you would want them to know or anything you would want to tell them?
I'd say one, talk to your colleagues or talk to somebody that's been there or someone like myself or whoever is in around your milieu to be able to reach out. I think being frustrated with the system and keeping that to yourself is unhealthy in probably many different ways.
Hmm.
Um, I think understand that early in your career, you're going to have frustrations and your career is not a linear thing. Your career has ups and downs like the rest of our lives do. Right. And there's good days, bad days, and it's how you deal with the bad days that give you the ability to have success and create more good days.
Hmm.
And really that's what you have to take away from, when everything's great, you don't learn anything from that. You learn from when things aren't great and what you did to dig yourself out of that hole. And so people want to avoid conflict and avoid stress and avoid setback, but that's when our greatest learning happens, when your resilience is built, when you can reshape what your goals are in life. So I think don't you can welcome those things, understanding that they all play a part in your future development and not want to avoid them, but you don't have to do it alone.
Hmm.
I think that's the biggest thing is that if you are experiencing those things or you have challenges, talk to somebody, talk to the system, talk to the nurses, talk to your administration. I think we develop narratives in our own mind. Sometimes a surgeon is like, I'm just not allowed to do this, or no one understands me. But being able to communicate those things, respectfully and meaningfully to the right people and engaging them, I think makes it better. And I wish I'd done more of that earlier on in my career because seeing now how it's able to affect change, I've really been able to learn a lot from that.
Hmm. You've said in the past that if you're not expanding your knowledge by, I think you said 5% per year, that you risk becoming a dinosaur. So, what's the 5% you're chasing right now?
So first of all, I learned that from Chit Ranawa, God bless. He was the one who said like he said, Sebastian's like, you got to be expanding your mind like by 1 to 5% every year, otherwise you're falling behind. And
Hmm.
you realize that later on, like with everything, if you're not moving forward, you're gonna fall behind a little bit. And I think that's important. I think, we like to be comfortable. Being comfortable often means not doing anything, right? But that's inertia. And I think you have to constantly challenge yourself, be it professionally, be it a technique, be it socially, be it, in your hospital system of how you can do better. And I think that if you just adopt that mentality, I think generally in life, that's what lets you go to the gym and try to be a bit better than the next day, or, read the paper and become better educated about world events in certain areas that you don't know about. Like, I think being able to constantly learn, I think is as surgeons, we all have a level of competency where you've shown academic prowess to a degree where you're able to learn. That doesn't stop when you start practice. And I guess when I
Hmm.
first started, I sort of thought that did like, okay, I'm done. I'm done my fellowship. And people always said like, oh, medicine is a lifelong learning journey, but you really have to be active in that. You can't be passive in that. You have to seek out new opportunities. You have to seek out things that make you uncomfortable to be better.
Hmm. What part of your practice are you, let's say, most proud of that your patients never get to see?
Um, I think if the relationship, well, that they never get to see, I think is sort of like the mentality here of the hospital when we first brought in like the first anterior hip program in this whole region of Toronto, and we brought in the first same day hip program. You know, what I was proud of was that the nurses and people involved were proud of it. So everyone from registration at the desk to the nurses to the OR people, they had ownership of that program, knowing that they were exclusive in the entire region and that they were teaching other people. They had a sense of ownership that, I don't know, makes me almost emotional because they liked the program almost more than I did. And it really showed in their work because patients would comment on me. They're like, we go to a lot of public hospitals or we go here and people aren't as happy as they are to be working where they are or notice those things. And those kinds of comments really highlight all the people that are part of that process for that patient journey But the fact that they owned it and love it and are proud of it, I don't think there's any way I couldn't be more happy with that entire process, because I can't teach that, but to know that they were able to achieve that, and it echoes with patients, though they don't know why exactly, but they know people are better here. That I'm really proud of.
And one last question for you, Sebastian. When your fellows leave your program, what do you hope that they carry with them that has nothing to do with implants or approach or even efficiency?
I think patient care, I think, is very important. I think being able to have a relationship with a person, I think we forget bogged down sometimes in terms of volume and numbers and x-rays, and behind every x-ray is a person, right? And they have a life story. They want to play with their grandkids, they want to go back to work, they want to heli ski, whatever their story is. Don't forget that that story is what brought them to you, and respect the fact that they're trusting you to operate on them. And I think that you have to remember behind everything that you do is a person. And so you have to have a relationship when you talk to them in consultation, when you see them in follow up, and respect that everyone recovers and prepares differently for surgery, and their experience will be very varied. But be open to learn from that and respect the person to try and, you have to remember why they're here and get better. And sometimes we say, well, your x-ray looks fine, you're fine. But we have to address what their issues are, their concerns are. And that took me a long time to realize, is that, like, even if you do something and everything is right, if it's not right for the patient, then maybe we haven't done everything right.
Hmm. Well, Sebastian, I really appreciate you taking the time to be with us today on the AHF podcast.
My pleasure. I can't wait to see you in Nashville.
Well, that's all for today's episode of the AHF podcast. If you found some value in this conversation, I'd ask you to share it with a friend or colleague, or just drop us a comment to let us know. And make sure to connect with us on LinkedIn to join the discussion between episodes. There's a link to our brand new LinkedIn page in the description. Find us every Friday with new episodes on Apple Podcasts, Spotify, YouTube, and all major podcast platforms. I'm your host, Joe Schwab, reminding you to keep those hips happy and healthy and home the same day.